Hi, this is Katrina English, and welcome to Week 2 of Legal and Ethical Issues for Health Professionals. This week's topic is Chapter 2 from our text, Contemporary Ethical Dilemmas. The text actually addresses many real-life, everyday ethical dilemmas that come up in my work as a healthcare lawyer for a hospital system. I read all of your introductory statements, and it sounds to me like many of you are already working in healthcare environments and facing ethical issues, perhaps not necessarily the ones that were addressed in this week's text, but real-life ethical issues in dealing with patients. And so hopefully this discussion will be important for you and will help you learn to develop a framework for analyzing and addressing ethical issues and dilemmas. Understanding theories and principles of ethics help us as healthcare professionals guide patients and their families through conflicts when ethical dilemmas are presented. And with this week's module, we're going to review current issues in modern healthcare and real-life ethical dilemmas, and hopefully allow you to examine how you might react to ethical dilemmas and process your decision-making based not just on your personal beliefs, but using a framework of knowledge, wisdom, experience, evidence, and decision-making combined with policy. If you work in a healthcare environment, there is likely a policy that applies to some of the ethical questions that will come in front of you. We certainly have to take into consideration the law. Lots of references to legal cases and legal decisions in this week's text, and then societal norms and expectations. We'll start with a brief little review of Week 1. Just wanted to make sure that we had down these 4 principles of ethics. The first is autonomy, or the concept that individuals have the right to privacy and the authority to make their own decisions. In our American culture and American legal system, autonomy is a very strong right, and it's generally understood to stand for the principle that a patient has the right to make the decision that is best for him or herself, not necessarily best for the healthcare system or for society at large, but we allow patients to make decisions based on their individual beliefs and desires. Healthcare providers have an ongoing duty to provide good, or that concept of beneficence. Healthcare providers are to serve the best interests of the patient and do what's right for the patient. Healthcare providers also have the corresponding duty of non-malfeasance, or that concept of do no harm. Again, always making sure that we're doing things that are beneficial or good for the patient. And then finally, the concept of justice. Our writing assignment for last week was on this concept of justice and understanding principles of right and wrong, and how justice encompasses the law, social teachings, beliefs, theology, and our moral judgments. A lot of different things influence our personal sense of ethics. Your family certainly is one of the first influences on your personal code or sense of ethics. Your peers and your environment also influence your ethical decision making. From your earliest years, your parents or whoever raises you instill concepts of right and wrong. If you go to school, you get teaching on right and wrong. And kids also learn through the actions and behaviors of their parents and other adults. Your religious beliefs also impact your personal ethical beliefs. Religious beliefs are a set of moral rules or spiritual laws that apply to you. You, even if you don't follow a particular religion, probably have some spiritual beliefs, or some people have none. Some people believe that there is no God, there is no spirituality, and that also impacts the way that you address ethical issues. For example, Mercy College and the Mercy Healthcare System are Catholic institutions and follow Catholic social teachings. And there are a set of guidelines known as the Ethical and Religious Directives for Catholic Healthcare that govern much of the decision-making in a Catholic healthcare system such as Mercy. These ethical and religious directives address many, many issues, such as providing quality care to the poor, as well as the social concept of not performing sterilizations. And we'll talk a little bit more about that later, but I want to mention that definitely impacts the way that we make ethical decisions for our patients and families in our Mercy healthcare system. And I am often charged as counsel for Mercy to make decisions that are consistent with that Catholic social teaching and the ethical and religious directives, regardless of whether it's consistent with my personal belief set. I'll put a reference for those ethical and religious directives in the resources section of this presentation. Culture and ethical norms certainly impact the way you face or consider ethical issues. Ethical norms and expectations are built around customs and the traditions of a society. For example, your views and the way you consider racism, gender discrimination, and certain prejudices are probably built up around the tradition of the society in which you were raised or the environment in which you were raised. I'll give you an example from real life. Years ago, when I worked in Columbus in another healthcare system, we had a large portion of our patients who were from the Somali population. And in the Somali culture, men are the decision makers, even when the healthcare situation involves a female. And so I was involved a few times in situations where we had a female patient in one of our hospitals, and we believed that a decision was being made for her regarding her health care that she didn't agree with. And our ethics team would consult, our legal and risk management folks would get together, and we would talk about what we would do. And according to our American culture and norms, that woman was an individual and she should have the right to make the decision that she wanted to have made. But according to her societal beliefs and norms, if she was married, her husband made decisions for her. If she was not married, another man in her family, perhaps her father or a brother or a brother-in-law, would make her decisions, and not necessarily with regard to her beliefs or her desires. We really struggled with those decisions, and I will tell you, in almost every case, the men made the decisions. And even when we would work together as a team to try to educate the men on why we thought the woman ought to be able to make a decision, or have an opportunity to have a conversation separately with the woman, we almost always came to the conclusion that with that particular group of patients, men were going to make decisions on behalf of women, and we had to learn to understand that. So let's move on and talk about how your experience can shift your ethics. Certainly the experience that I just described shifted my ethical framework and caused me to look at a situation that I used to think was right versus wrong and look at it through a different scope or a different lens when I considered the way that individuals in the Somali culture looked at the issue as compared to my very American viewpoint. Internal reflection is also important. Exposure to situations, just like the example that I gave you, let you see the impact it has on real people and the fact that people do approach these issues from different perspectives. Your personal beliefs, as we've been talking about, do impact your decision making. What bias do you bring to the situation? I am an educated American woman. I look at things differently than someone from a different culture or a different socioeconomic background. My experience impacts my view. I have not yet been in a situation where I have had to make a decision about withholding or withdrawing life-sustaining treatment for a family member. I think I know how I feel about those things, but I won't know for sure until I'm in a specific situation that impacts me directly. Then when we're looking at these ethical issues, we also have to ask, can we approach the issue from a position of neutrality? When you are engaged in making a decision on behalf of a patient and not yourself or your family member, or when our ethics team or a member of my legal staff is helping to make a decision, we have to look at what's right for the patient and the family from that lens of neutrality and taking into consideration that patient and family's beliefs and feelings, and combining those with the hospital policy, with the law and legal restrictions or requirements, and then certainly what is achievable, what can we do. You have to be able to learn to separate your own personal beliefs from a situation and make a decision using the framework that I just described. Healthcare ethics is interesting. Sometimes we have to be willing to do things that patients and families want us to do that we aren't necessarily on board with personally. In situations where we can't feel comfortable taking an action that a patient or family wants us to take, sometimes as healthcare professionals we have to disengage, transfer the care of the patient. For example, I was discussing earlier the ethical and religious directives for Catholic healthcare, which prohibit sterilizations for the purposes of birth control. So we may have patients who, from a cultural perspective and even from their own personal set of religious beliefs, feel very comfortable with a vasectomy or a tubal ligation. We don't perform those procedures in our hospital if they're for the purpose of sterilization. We can only perform them if they're for the purpose of preserving the life and health of our patient. So in those situations, we have to transfer the care of that patient to another institution, to a non-Catholic institution that is able to provide that kind of care. We don't disagree. We don't criticize the patient. We just don't provide those services in our facility. In other situations, patients demand care and treatment that healthcare providers just don't feel comfortable providing. We've had a situation that I've been aware of, not at Mercy, but in another system where I worked, where a family made a decision that the hospital supported based on its policy and the law. This family was making a decision to withdraw life-sustaining treatment, or essentially to pull the plug from a patient. It was a very difficult decision. The family and the hospital administration and the caregiving team went through all the appropriate steps and made what was an ethically and legally supportable decision. But one of the nurses on duty the day that the life-sustaining treatment was to be terminated did not feel it was appropriate to ever withdraw life-sustaining treatment. That was a personal and religious belief that she held. In that situation, we were able to excuse the nurse from that situation and not have her be part of the termination of life support for that patient. So the patient and family were able to accomplish their objective and do what they believed was right, but we weren't going to put our healthcare worker in a situation where she had to compromise her personal sense of ethics. We have to balance the desires of patients and families, and we can't always accommodate everything that they want to do. We have to look at what's best for the patient and family and work together with them as healthcare professionals to make difficult decisions about treatment options. As I said earlier, we approach these things from different religious and cultural and socioeconomic perspectives. And again, it's important to understand that a big part of what we do when working with patients on these issues is to try to approach this from a position of neutrality and look at it from the patient's lens, look at it from our lens, kind of compare the two, look at what other types of legal issues might be involved and hospital policy, and make the very best decision that we can. So let's talk about some common ethical questions. The text addresses a lot of common ethical questions that really do come up in everyday life in our work as healthcare professionals. When to start or discontinue life-sustaining treatments is one of those discussions, and we'll have a lot more discussion, a lot more opportunity to delve into that issue next week. What if a patient refuses treatment? I've actually seen situations, and maybe some of you have too, where patients have decided that they just don't want a beneficial treatment. Maybe it's chemotherapy for a cancer patient, or maybe it's a surgery for a patient who has some type of coronary disease, and we see a patient who is viable and potentially could benefit from the treatment, have good quality of life, and maybe many years to enjoy afterward, and the patient says, no, I'm not willing to do that. I don't want to put the chemicals in my body. I don't want to undergo surgery. What can we do? At the end of the day, the principle of patient autonomy is the legal principle that will win out, and the patient gets to make the decision. That's not to say that as healthcare professionals who have that duty of beneficence and non-malfeasance, that we won't try to talk the patient into making a decision that we believe is in his or her best interest because we believe it actually will do good. I've certainly been in situations where I've seen healthcare providers take multiple attempts to convince a patient to consider a course of treatment that they believe is beneficial. And when the patient says no, then the answer is no, and we have to move on. One of the other issues we have to address is who makes decisions for patients who are unable, and how do we resolve conflicts. That's something that actually does come up somewhat frequently in my everyday work, are situations where patients have not executed a durable power of attorney for health care or another type of document that names a healthcare proxy or a surrogate decision maker. And we have family and friends standing at the patient's bedside disagreeing about what to do. And one of our jobs is to help people make the best decisions that they can, but also to understand who gets to make those decisions. Fortunately, the Patient Self-Determination Act has helped us with some of that. And if the case where a patient has executed documents, then we can look to those documents to see who the decision maker should be and which decisions the patient might want made. In situations where there is no document, Ohio law actually has a hierarchy that tells us which family members to go to and in what order, and that provides us again with a framework for making decisions so that we can have that conversation. Ultimately, in my experience, most of the decisions, although they're made by the decision maker who's named in the healthcare proxy or the durable power of attorney, or they're named by the appropriate person in the statutory hierarchy under Ohio law, they are actually considered by an entire family unit. One of the best things that we can do in the hospital through our spiritual care staff and our social work staff and our ethics committees through ethics consults is to sit down with the family and actually talk through the issues and try to get everyone to consensus, even though there may be only one family member or one group of family members who is actually the official decision maker. It's helpful to have that conversation, and in most cases you can get a family on the same page. If not, then our job is to take a step back and say, hey, Ohio law is specific about this. This individual or this group of family members gets to make the decision, and at the end of the day, their decision will stand. One thing I did want to mention, just because people get nervous about these discussions with end-of-life decision making, is that in an emergency, it's always okay to do what you think is in the best interest of the patient. That's a common legal principle. There's immunity for healthcare providers who, in the case of emergency, go to the option of giving treatment and sustaining life. That's appropriate to default to that option in the case of an emergency. So let's talk a little bit about some current ethical questions that weren't addressed in the text. Text does a great job of discussing in some detail some current ethical dilemmas that we all may be aware of, but let's talk about some other things just so we can kind of frame up how these conversations occur. One of the first issues that I thought of when I was thinking about this issue is the concept of childhood vaccines and whether or not parents should be able to object to their child receiving a childhood vaccine. Some people question the effectiveness and safety of certain vaccines. Some people question whether they work at all. Some people think that certain vaccines are unsafe. For example, there is a pretty widespread belief that the MMR, or measles, mumps, and rubella vaccine, may cause autism. That belief and the belief that, and actually the legal concept that patients have the right to make medical decisions for themselves has to be weighed against the public policy and safety concerns of preventing measles in our society. And since parents have begun refusing the MMR vaccine, we have begun to see outbreaks of measles across our country. Measles was a disease that was previously eradicated in the United States, and it's back now due to the fact that not as many children are being vaccinated. And so the question at play here is, do parents have the right to make a decision on behalf of their child that may potentially endanger another child or society at large because the measles disease is now back and it's a prevalent part of our society? Those are very interesting, difficult questions. Similarly, if you work in healthcare, you probably had to have a flu shot if you work in a healthcare setting. Mandatory flu vaccines for healthcare workers are now required by the agencies that accredit healthcare institutions. So if you work in a hospital, even if you work in an office job like I have, you're required to get a flu shot every year. Again, similar to the MMR vaccine issue, there are people who believe the flu shot either is ineffective or unnecessary, may contain levels of mercury and other things that are harmful. And individuals have objected to the idea that their employment is conditioned upon the requirement that they get a vaccine. There's a lot of case law out there. This concept has been challenged many times, and so far the healthcare workers who have challenged this mandatory requirement have lost. And here again, what you're weighing is that right of autonomy and the right to decide for yourself versus patient safety and the health of employees. So far, just about every major national healthcare association has endorsed mandatory flu vaccines, has said that they're effective, evidence-based, it's ethical to mandate the vaccine, and that it's necessary for patient safety and the health of all healthcare employees. There are exceptions, as you probably know, that are offered for health reasons. If for some reason you can't have the vaccine for a health reason, you have an allergy, or if you have a religious belief against receiving the vaccine, you can get an exception. But again, you have to go through the exception process. You can't just refuse. You need to demonstrate that you have a reasonable reason for not getting that vaccine. Again, the law supports this, but that's an ethical question that's out there, and many healthcare workers feel that they are being unfairly and unjustly forced to get flu vaccines. Another interesting ethical question is the concept of allocating healthcare dollars and resources. Some people call this healthcare rationing. If you were paying attention earlier in President Obama's administration, while the Affordable Health Care Act was being established, you would have heard some discussions about rationing. And in particular, I put in here a quote by Ezekiel Emanuel that I thought you would find interesting and maybe would spur some thoughts for you. Ezekiel Emanuel is a bioethicist. He was an advisor to President Obama. He was an author of many parts of the Affordable Care Act, which is also known as Obamacare. And he's been a leader in discussions in this country around health reform measures. His platform often is around how are we going to control cost? How are we going to get costs down? And should we be discussing who is getting medical treatment, who should be deciding who gets which medical treatments, and frankly, whose life is worth saving? So he has initiated some very interesting conversations with a lot of ethical implications about balancing the needs of an individual patient with the best interests of society. And his position is one that supports a government-sponsored healthcare system for everyone, in which the government makes decisions about how much healthcare any one individual should get. And he actually advocates refining or changing doctors' ethical obligations and healthcare professionals' ethical obligations to consider the greater good or the benefit to society versus one patient's needs. So, for example, a very expensive cancer treatment that has not yet proven to be effective is something that patients may fight to get their insurance to cover. And if they can get insurance coverage or if they can pay for it themselves, they can get it right now. And many physicians would feel that if the patient wanted it, the physician would need to provide it, because the patient has the individual right to make the decision. Zeke Emanuel would say, wait a minute, I don't know. If the government were in charge, I don't think the government should be responsible for having to pay for that if we don't know that it's effective and if we don't know for sure that it's going to result in a good outcome. He would say in that situation, the patient either needs to pay for it him or herself, or they need to forego it on behalf of the greater good. So his position is that the government's role is to provide for the common good, and in this way they can reduce healthcare spending and waste, and folks can be more responsible for personal accountability. There's also this concept that is accepted in other countries where the government does sponsor the healthcare system, that individuals are accountable, and individuals who are not taking care of themselves, are not managing their weight, not managing their diabetes, are drinking too much or abusing other substances, in some situations, are not entitled to health care until they address those health concerns that they can control. There are also waiting lists in other countries for things like hip replacements and knee replacements, and decisions on the priority of those wait lists are based on factors like the overall health and age of patients. For many Americans, that's a very scary concept, and that's considered rationing. For people in other parts of the world, and for people who think like Ezekiel Emanuel does, that's really just making healthcare decisions that are in the best interest of society and setting aside the personal interest of each individual patient in favor of the best interest of society. There are a lot of current ethical questions around conflicts of interest. I see this in my work every day. For instance, in the selection and purchase of medical supplies and devices or drugs, we ask our healthcare professionals to be careful that they're making objective decisions and aren't being swayed by vendors who come into their office practices or come into the hospital and offer free samples or a trip to the Super Bowl or some other fantastic perk in exchange for using the drug or the medical device that they're selling. There are ethical issues around treating family members and generally ethical rules that indicate that physicians and other healthcare professionals should not directly treat their family members because they are not able to be objective in those situations. When it comes to medical research, this was addressed a little bit in your text. Questions around, really not questions around, requirements around ensuring that appropriate informed consent is provided and that patients know all the risks and benefits in a situation where they've decided to be part of an experimental research activity. Around the use of experimental drugs, there are a lot of questions about using drugs for what are called off-label or non-approved FDA uses and how much regulation is appropriate by the Food and Drug Administration. You've probably also seen in the media the issue of availability of drugs in other markets. Drugs that are either unavailable on the American market because they have not yet been through the formal FDA approval process, or are available in the American market but at a much, much higher cost, are accessible from Canada, Mexico, and other places, and particularly with the advent of online ordering and inexpensive shipping, people are getting access to drugs at much, much lower cost, and there are some issues that are interesting to consider around whether or not Americans should be able to get drugs from foreign sources, and at what point the American cost for those drugs needs to be addressed so that we can provide them as inexpensively as other countries. And then finally, you looked at a number of contemporary ethical issues in the text. And as you looked at those issues, I just want to remind you that the background that you bring to this as a healthcare professional and all of those factors that we talked about, your family, societal and cultural norms, religious beliefs, your experience, those are all useful for helping patients and families resolve dilemmas and making the best decisions. It's very helpful to have policies, and we'll be talking about that in next week's lesson as we talk about the role of ethics committees and how they help establish policies and procedures for healthcare institutions and healthcare professionals. Education and research help us make better decisions. In the legal system, lawyers strive to resolve disputes and make judgments based on evidence and research. Usually one of the first things I do when presented with a question or a dilemma, whether it's an ethical dilemma or just a question, is to step back, think about what I know. Is what I know factual? Is it evidence-based? Do I need to do more research? Do I need to get more information? What other perspective can I look at the situation from? And then we engage in respectful debates. Respectful debates have to occur, and I can tell you, when we are considering difficult decisions involving patients and families, there are debates amongst the caregiving team. And again, I know some of you have experience, and you have been part of those debates or part of those discussions. Those respectful debates are healthy, and they must occur. There are always going to be differences of opinion. There are oftentimes many lengthy debates and discussions as we develop policies and procedures. For instance, earlier in my career, I was more involved in lobbying on healthcare issues. And I was actually working in government relations at the time that Ohio's Patient Self-Determination Act was passed, at the time that Ohio passed its law on do not resuscitate orders. And one of the statutory requirements was that the Department of Health, the Ohio Department of Health, establish a set of forms and a set of rules for DNR orders. It took the better part of 2 years for a committee of healthcare professionals and lawyers and legislators and patients to come up with a common set of rules, which still are a little bit clunky and don't always work well and have just recently been refined. So these discussions are difficult and time-consuming. And again, as I said at the beginning of today's lecture, a lot of the issues are not right or wrong or black and white. They're a matter of policy development and trying to come up with the best solution for everyone. Sometimes we have to compromise. Sometimes we have to look at the outcomes and balance the interests of everyone. But again, it's important that we respect the thoughts and opinions of others, that we follow the law, and that we also are mindful of institutional policy and any other requirements that we need to be complying with as we make these decisions. So that really wraps up the discussion for this week. I hope that it caused you to realize that you can think about these ethical issues as dilemmas, and that you have a whole framework that you're building for examining and considering these issues, that to the extent you are providing care as a healthcare professional or working in an administrative role similar to mine, that you are definitely an important part of helping make these decisions on behalf of the organization that you work for and on behalf of your patients. Next week, we'll get into some more in-depth discussion about end-of-life decision-making. It's a topic that I find to be fascinating, and I've had the opportunity to do a lot of research and teaching on, so I hope we can engage in some meaningful discussion. And we'll also talk about the role of healthcare ethics committees. And again, something near and dear to me, I have sat on a healthcare ethics committee for probably the last 15 or 20 years of my career, and I hope to be able to share some interesting stories of my experiences there with you. In the last page of the PowerPoint, there is a list of resources that you may want to consider as you're doing your web review, or if you just want a little bit more information on any of the topics that I've discussed today or appear in the textbook. I hope that you have a good week. I hope that you find this week's lesson engaging. I will warn you that the reading burden increases next week. We're going to complete 2 chapters, so please plan your time accordingly. And I look forward to reading all of your discussions and engaging in some respectful debate of these issues with each of you over the course of the next week.